that is so 12.5. I'm sorry, 10 milligrams of oral is equal to 12.5 of decanoate. So instead of looking at it like I specifically put in the slides for you guys 1.25. If you look it up in Micromedics, it says convert for every 12.5 to 10. So I just did the smart thing and said, okay, take your dose and times it by 1.25.
Right.
The Stimmel method in the textbook does it by 1.2, and they say you can give it every week for 4 to 6 weeks. If you look it up in some of the other dosing strategies, it says give it every 2 weeks because that's where most of the studies have been done. Some of it says do it every 3 weeks. So the largest pool of literature out there and dosing recommendations, according to even the package insert, is every 2 to 3 weeks. And so I just basically said, instead of saying 12.5 to, the 10 to 12.5, it's essentially taking 1.25 your oral and giving it every 2 to 3 weeks. Same concept as Haldol conventional dosing. You give the first dose, you supplement to the second dose. For fluphenazine, you can give that 1 week later, and then you don't have to orally supplement.
Right.
And you just go every 2 or 3 weeks after that on average. The rationale is that when you're starting out, and again, this kind of goes, it kind of overflows a few of the strategies out there, but when you look at how it's generally dosed, they like to get rid of the oral as fast as possible, so that still allows you to do it on the second week, okay? And where all the studies still say that you can do it every 2 weeks, it gets rid of that weekly dose that most people aren't going to keep up with for 4 to 6 weeks and want to have that drug be something that they're utilizing. So it breaks that out a little bit more. And the idea is that, when you're looking at most of the studies that are out there, and I'm sorry if I'm going into more detail than you care about for what you need to know for Monday, but most of the studies that are out there, if you stop and you look at all of them that have been done, though they're using 2 weeks, when they've compared them to the ones that they're giving every 3 or 4 weeks, because it says it can last up to 4 to 6 weeks, right, even if you're giving one. We know it's shorter acting than Haldol, so they usually still err on the side of caution to go more towards the 3 weeks, even though the 2 weeks versus the 3 or 4 week studies don't necessarily show that there's more improved benefit with the 2. To err on the side of caution and non-compliance and everything else with patients, most doctors, if they're on Prolix deck, will stick every 2 to 3 weeks. And that's kind of why I said for class, clinically what you need to know. If you want to look at your Stimmel method separate from that and know that that's out there and it exists, that's totally fine. But rule of thumb, 1.25 every 2 to 3 weeks is how you'll actually see it dosed.
But your big one's Haldol. Really, that's the one you're probably going to test.
I would say it depends on where you practice.
Yeah.
I have a doctor right now that loves Prolix deck. Half his patients are on it when he can do a deck shot anyways. That's an appropriate long-acting. The vast majority, I would say, yes. I would say you're going to see more Haldol decanoate than you'll see Prolixin, just because Haldol is a bigger drug. So.
I've seen mostly Risperdal Consta, to be honest with you. I don't know that I've ever dispensed.
Well, if you're community pharmacy,
Community,
because a lot of the time what they'll do is they'll have the patient pick it up and then they'll go to an office and have the office administer it. And realistically, if you're talking about how you're going to dose the drug and you're giving Consta, you might as well just give them Invega. So it could be every 4 weeks.
Yeah.
But, the cost comparison is not that much different if you do the Consta every 2 weeks versus the Invega once a month.
Yeah.
It's pretty similar. So, but yeah, the long-actings, to know which ones are available, in the last couple years, we've completely and totally shifted our thinking on how we would appropriately treat patients first line. And if you can recognize a pattern of a non-compliance, if you can recognize a pattern of improved adherence for any reason, you're going to go towards that model in a schizophrenic population. So they've now said, there's no reason not to think from day one, your first line therapy, to have a long-acting in mind. I generally am going to say the vast majority of your doctors in the literature isn't saying that we still don't look at POs as a first line option. But it's those patients that you're looking at as a higher risk, that's absolutely appropriate. So you definitely need to know which ones are available and their frequency. If you want, let's see, let me pull up my, like I said, I'm about 90% done with it. There's a couple questions I'm going to go back and toy with, but I'm going to go through. Are you guys, you're probably not coming Friday?
Yeah, I'm coming Friday.
You are coming Friday?
Yeah.
I do, like, so I will do a much more focused review on Friday that kind of covers all of your highlights, because I know, like, I'll try and highlight stuff in class so you guys are kind of gearing in where to go, but I feel like some of that still gets lost in the scribble and translation of lecture. So I'll come out and tell you, like, focus points and what you can probably say a little bit with.
Awesome.
So you know, I don't go on and I won't tell you exactly what's on the exam.
Well,
I hate that whole standpoint. Just tell me what's on the exam. Well, I don't really want you guys. I want you guys obviously to think about Monday, but I could care less about your grade on Monday. I care more about, like, what you're going to retain and be able to, like, utilize. So that's how I actually gear my exam questions. So they're all geared towards what you would want to know and talk to a doctor about with this drug or this patient's side effects or those symptoms. So it's much more of that clinical focus. So if you're feeling like you're getting stuck on the diagnostic side, don't go crazy with that. You need to know your basics. So if somebody's presenting, you can recognize those symptoms and say, yeah, that looks like this diagnosis. Yes. I'm not going to say you don't need to know the symptoms of schizophrenia. We spent like a lecture on that. So, but the idea is that, like, if someone is having positive symptoms and I'm asking you, for example, let's say I have, you know, someone who's obese and it's their first time that they're being diagnosed with schizophrenia. You know, let's say they had the prodrome, they're active symptoms for, say, a month, right? And they're clearly having schizophrenia right now, okay? So, you know, if I were to say, give me a treatment recommendation, you have to be able to take into certain considerations what's going on. If they're, you know, only exhibiting positive symptoms and you don't really see as much of the cognitive issue or negative symptoms on board, and I were to give you, like, say, Zyprexa and Haldol, Haldol is actually a better option than Zyprexa on someone who's already got metabolic syndrome, right? Right. But if I'm asking you which medicine treats more of the complete illness, Zyprexa is the answer. Right. So that's where, like, I know it gets hard for you guys to do that, but when you're thinking of best therapy, you have to kind of have that understanding of where to use what, and that's kind of where I'm going to gear my review towards,
okay.
If that helps at all. Yeah.
So for someone who has who is like obese, or like for the previous case study that we had for the major or big concern of the girl was she was going to stop medication and she gained weight.
Mm-hmm.
Is that I guess my question is, do we want to, like, focus more on, like, treating her schizo or treating like the metabolic side effects that will happen?
So this is where, like, where I like doing SOAP notes, because you have to look at your top priority down to lowest priority. And clearly her psychiatric condition is going to be your top priority, because if that's off, everything else is going to be off. She's not going to be paying attention to how she's eating, taking care of herself, all that. So you clearly have to address the psychotic piece, but within your toolbox, there's better options than others to kind of make sure you're still maintaining the safest drug for that patient. So, you know, in that example where she was on quetiapine, right, even if it's effective, she's clearly having issues where she's telling you, I'm probably not going to be compliant if this keeps up. So even if it's working and she's becoming clear, she hasn't been on enough other medications that I would say, you know what, this looks like it's an adverse drug reaction the patient is not willing to accept. Do we have other items that we can switch to? There might be instances if they're on clozapine and it's working and they're having all these side effects that no, we've already failed other therapies. And this is actually keeping you lucid, and we're going to have to deal with that separately. But if you're not talking treatment resistance, if you're talking, I mean, you could even have put somebody on, it gets kind of hairy, because the idea is if I have somebody who responds well to therapy but stops taking it because of an ADR, that's not treatment resistance, right? That is an adverse drug reaction, so you're switching to another med. So for weight gain, like her, you could pick another medication that with the idea that the atypicals all have, in terms of efficacy and metabolic syndrome, a lot of differences, right? Efficacy is there, but metabolic syndrome, big difference. So to say aripiprazole, sure. If you're thinking you want to stick with the clinical way, would be like if I have, I probably would say aripiprazole is an easy one, right? Everybody always remembers aripiprazole is the lowest. But if I were to give you, let's say all the penes, say I gave you olanzapine, I gave you quetiapine, I give you asenapine, and I gave you, oh my God, asenapine. But you get what I'm saying, like out of your options, let's just say. You've got your pene, and you know, if I'm telling you that, you know, asenapine seems to show a little bit less of the metabolic complications than our Seroquel does, and it's structurally similar, clinically that's where you're going to go. I'm not going to ask you guys those types of hairy questions on the exam. But if you have that understanding, you're going to be able to answer those questions on the exam too. That's kind of why I bring up both sides in class. So for Monday, what I would say is if you have a patient that has an ADR, I will always be very specific on how I write the question. I will always say, due to her side effects, what is the best option in this case? Or I will say, because of the current symptoms she has, what is the best option? I will always be specific. I won't leave it in a gray area for an exam question. I can assure you of that. Okay?
Would it be like a free response where we would have to like say, I'm choosing this because of these reasons?
Or is it multiple choice?
No, everything is either a one-word fill in the blank or a matching, or it's the same as the quizzes. So it's not like, you know, I haven't done any like short answer like questions historically, because I'm trying to, if it's a fill in the blank, it's something that probably could be turned into a multiple choice, because I try and keep it NAPLEX minded in the way I write the exam. So if it's fill in the blank, it's usually because it's like a key fill in the blank from something I highlighted in lecture that I want burned in your brain. You know, like, so if I were to say, give me a long-term complication of lithium or something like that, you know, and you've got your short-term and long-term we talked about. So like, you should be able to think about like, okay, so hypothyroidism is something that's going to happen a little further. Those types of examples, like, that would be the furthest I would ever take it. And I'm not even saying that I have a lot of them on the exam like that, but that would be like the furthest I would take it. I usually stick to, you know, give me the best choice that you would treat this patient with. Those are like a multiple choice. And I'm not just going to leave it freelance. Like,
so there'll be obvious choices. It's not going to be like, you know,
Yeah.
Cyprexa and
Yes.
Seroquel, like all grouped up like into the, like
Yes.
all the atypicals and, you know.
Yeah.
There'll be a
What
variety
I will say is the only time that you might have like more than, like, for example, like matching questions, kind of like on like I've done on quizzes, where if I were to give you like a list of atypicals and I were to give you a list of side effects and say match the most the side effect that corresponds to each drug best.
Yeah.
There could be more than one right answer if you were to talk about something like EPS.
Yeah.
You know, there could be you know, more that would be applicable for like weight gain.
Right.
Right. But if you're looking at most, then you have one best answer for those. Yeah. Like, but I don't try and trip you guys up. It's going to be like,
it's hard enough without you trying to do that.
Right. I don't need to. I want to see what you know. I'm not out there to try and do trick questions.
That case study is not posted.
It's not.
It's not. I've been looking for it all week, and I checked again after class. It's not posted. Because I wanted to start on it earlier.
I'm glad I brought it up, because otherwise...
And the idea is, I just want to clarify, you expect us to have that case study done before we even get to class? Because we only had like 10 minutes to talk to our group, and everyone was like, I don't know what's going on, I don't know what's going on. And then we started answering questions, and nobody knew what was going on.
All right. It showed me when I pulled it up it was posted. That is so whack.
I had somebody else check it too, and they couldn't find it either.
Yeah, I checked it right before I came.
Yeah, it's okay.
I'm going to take a look right now. I'll make sure it's up. This did this to me in Therapeutics 3 earlier, and there was like some checkbox that like randomly was on it that I didn't even go into.
Yeah, Blackboard kind of sucks.
Oh, I hate Blackboard.
Yeah.
It's the first time I'm using it at uni. We had eCollege or WebCT, or there was one other one I had used, and all of them are better than Blackboard.
Yeah. Yeah.
All of them are. All right. Let's see. This is. Teeter stuff. Stop it. Guys, we get slow in here right now. Here's my computer. Might be I have too many things open.
Yeah, that happens.
It's showing that you guys can view it. I might just delete this when I post it. Oh, I see. Hold on. It's like. Because it was put in an assignment for it's the release date. Okay. It automatically populated the release date is not tomorrow.
Gotcha.
Oh, I can't believe nobody said anything. Oh.
Well, I had been checking all week, and I'm like, okay, maybe she just doesn't want us to dig into it
Oh
yet.
God,
She
no!
wants- yeah.
I always have stuff. I always have my case up a bare minimum a week, so you guys have
Yeah.
time to work on it.
Yeah, and that's the idea. You want us to work on it before we get to the
Right.
class, so
it's
that when
easier
we get
you
together
actually
as a
are
group,
meeting up.
we're just going to say, okay, what'd you get? Okay, and we're ready to go. Because we didn't get that concept, and I don't think anybody, except for a couple of us, had it done. I only had it halfway done before we got to class.
Okay.
So we were all thinking, okay, let's dig in, and then you started asking us questions. And
I'm totally aware that like it's a learning curve because you
is.
guys aren't ingrained with the normal, and I'm trying to slowly get you in shape. And Dr. Allen's going to kind of come in and be like, "Here we go," and so, you know, but yeah, like you'll be totally entrenched in it soon enough.
yeah. Okay, looks like I have it now.
Got it?
It's thinking.
Yeah. There's like this second tab release date thing that somehow got flipped off on there. I don't know what happened. But
There it
okay.
is. Yep, it's there.
I mean, the idea is that you have the idea what you would do, and then the group discussion kind of pulls like the best
Right.
answer together. So it's not like the end of the world going through this, but it makes it a whole lot easier when you walk into case study and you're prepared.
Oh, definitely.
So, okay.
Yep. All right.
All right. So was there anything from like sleep disorders you guys wanted me to go over?
Can't even remember sleep disorders, to be perfectly honest. That was a couple weeks ago.
What is the role of mirtazapine and trazodone when it comes to sleep disorders? Because
So they are most appropriately going to be used for the indications of antidepressant-induced insomnia or depression or anxiety-related insomnia. They work great for that. Key is, remember, low dose for both of them. Mirtazapine, 7.5 to 15, is normally like kind of where you'll see the maximum benefit kind of tap out above that because the dual mechanism of action, the serotonin. So you'll end up having that agonism, antagonism, depending on the dosage, and then that alpha adrenergic activity kind of, all of that kind of gets lumped in, and you'll see a receptor flip. And so when you get up to 30, it may not be as sedating. It might still have some sedating properties, but it's not going to be as sedating. And even at 45, you may not even have as much of that sedating potential. Still works great as an antidepressant and for anxiety, but if you're thinking sleep, low dose. Same concept for trazodone. You're never going to go usually above 150 to 200 is the max. Above that, you're looking, antidepressant dosages are like 300 to 400 milligrams, right? And they're dosed a couple times a day. So I'm not saying if you're using them for an antidepressant for trazodone, you're definitely not just going to be dosing it at bedtime. So that's just for sleep at bedtime, low dose. And sometimes even if you have a doctor that starts you on like 50 to 100 and they're noticing they're not sleeping well, you'll actually see improvement if you bring it down lower 25 to 50.
So it's kind of counterintuitive because you always think, oh, more, make them
more is
drowsier, but
not always better.
Okay.
Right, yep.
On the case study from last week, we had decided for Thursday that Abilify was the drug of choice for the particular patient on that case. And my first thought was the patient had insomnia and Abilify can be activating, and I could just hear Dr. Teeter saying, no, if it's activating and they have insomnia, you don't want to give it to them. What would you have chosen? Is that what you would have gone with in that case, or what would you have gone with personally?
So the drug manufacturer for Abilify specifically says it's recommended to give in the morning because of the activating potential. That doesn't necessarily mean they're going to have insomnia later in the day. So if it's usually kind of like the peak of a drug especially, you'll see some of the side effects. So if you give it in the morning, you'll usually notice it. There's certain patients that take that and will sometimes even get sedated from it. So if that's the case, then sometimes we'll move it to night. The majority no, it's morning. So it doesn't necessarily mean if you're giving it in the morning that they're not going to be able to sleep at night. If they were to have insomnia, that's a separate thing to address.
Well, I think this patient had insomnia to begin with,
Right.
so that's why
Right.
I skipped Abilify and went
Yeah.
to Latuda.
Yeah. So the Carla, the movie star. So she was one of those cases that there is arguably more than one answer, but defend your decision because.
Okay.
So and that's exactly why I give those cases. Sometimes there's a couple things you're thinking of, and you go with this because you think it's the best answer because. And if you were to talk to another psychiatrist, they're like, I probably would have gone with this because.
Yeah.
So there can be more than one answer. The Abilify isn't a bad option. It would be okay to rule it out because you were concerned about, the potential activation, but it's probably not enough where I would say I'm concerned. I would probably address the insomnia if I had to separately and see if we could get her back.
And see, that's something I don't know that I personally can get that out of the slide. I see that you have listed on your slide it's activating, so in my mind that rules it out for insomnia. I don't know how
Right.
activating it is. I don't know that it's just
Yeah.
once in the morning and by the nighttime they should be okay. Things like it's the little subtleties that I'm concerned about.
Yeah, so, for the scope of an exam, okay, and that's why I like you, I want you to think about those things, and that's exactly where you need to be going for when you're practicing. That's perfect.
Okay.
For the scope of the exam, if I were to say, if Abilify would have a side effect of, activation and insomnia, that would be true.
Yeah.
It could be true. For if I'm looking at first treatment for her with all other things considered, potential for the waking like we had talked about,
Right.
for the insomnia, I'd probably say give it see how she does on it on a low dose.
Okay.
You would not be incorrect of looking at say a Risperdal or an Invega as well. Those would be good options because they also have the long acting agents, and compliance sounds like it's going to be an issue with her.
Right.
The one thing I would be hesitant on with Latuda if she's not eating normally.
Maybe it wasn't. No, it was an injection that I went with. Now that I'm thinking back to it, I think
Okay.
maybe it was Invega.
Okay.
Yeah, because I started working down the list. When I saw insomnia, I skipped Abilify.
And when I've
But I always start at the top and say, does this make sense? Can I use it? If not, then I go to the next. That's my thought process as far as the metabolic
there's not
syndrome
really
goes.
anything speaking against Invega.
Yeah.
Invega would be a very good option.
Yeah, I
for
think
her.
that is actually what I ended up picking.
Yep. Yeah, but that's exactly what I'm saying though. For the scope of an exam,
Mm-hmm.
I wouldn't be able to just give you I wouldn't just give a case like that and be like, what is the best option without telling you she is specifically concerned about Bob.
Okay.
You'll have a clear key on how to make the best recommendation.
Okay.
So. I'm trying to. I'm pulling up sleep disorders. All the other ones are in my recent. That was 2 weeks ago now.
So just zoom in more on the like side effects, more so than like diagnosis of like acute versus
For which.
for like either bipolar or schizophrenia.
You have to be able to recognize what phase somebody's in to recommend therapy. That's what I would say. So you do have to be able to recognize if somebody is acutely manic and they're psychotic versus, if they're hypomanic and this has been a persistent thing over the course of 2 weeks and they are looking at starting on a medication to prevent them from going into a depressive cycle. So, I should be able to tell you symptoms, like if someone is, just been treated for, like the case kind of we talked about in class today. That person had been treated 6 months ago and now is hypomanic. So it tells you that he's gone within 6 months from one cycle to another. So you're definitely looking at maintenance therapy. So, for example, like for the type of exam questions that would kind of relate to something like that, I would say acutely, what would be your best recommendation to treat his current symptoms at this time? What would be your recommendation to treat him for a maintenance drug that you would like to see him get stabilized his current condition? And I will either give you enough cues to say, okay, like he is clearly, you'll definitely be able to tell whether he's manic or hypomanic. I will make it clear if he's having hallucinations or delusions or psychosis. I will tell you something that you should definitely be able to pin that down. So as long as you can look at your overall diagnosis and you can tell whether it's acute or chronic, you have to have an idea of what therapies are going to be tailored for what stage. That's probably like, I know when we're going through the drugs, I'll say this is approved for acute and maintenance. This is approved for acute and maintenance. I think the easier way to look at it is look at all your drugs that you would recommend as your first line for acute and those that also treat acute, and then you look at your maintenance drugs, your first line acute, and your augmentation strategies to kind of help out along with the way there. So the easiest way I've always found even when I was going back and studying it as a student, like you kind of have to categorize where's that person at and the best choice at this point in time. Okay? Does that help? Okay.
This test is all your material, right?
Yes.
So this is just completely yours.
That's all mine.
Okay. All right, that's fine.
Yeah.
So make sure I get everything studied.
Yeah, that's kind of where I was going with it, like when everything shifted and we moved to ADHD. Like I actually taught ADHD since I started here, and I was supposed to be cutting back because I'm tenure track working on research and all that stuff, and my teaching load is a lot higher than other professors. So Dr. Cheater was supposed to pick that up, and then once the snowstorm came, he's like, I don't have a lecture like ready to go for this with all these snow days. So I almost ended up picking it back up, and I held off. I'm like, you know what?
Yeah,
you can figure this out. I still have to make up stuff from Therapeutics 3 and Migraine that I still have to put together. So, yeah. It is. I am under the assumption, just like I told you guys in class, and he definitely isn't giving me exam questions for Monday, so it's going to have to be that high stakes quiz that he talked to me about. So, and historically, again, I'm assuming we're doing the same thing here as we would do in Therapeutics 3. Like, our exam was 11.5% that we just gave on Monday, but because Migraine wasn't on it, I took that 1.923%.
Yeah.
That's how much the Migraine high stakes quiz is going to be to equal exam 2. So, yeah.
Makes sense to do that.
But I actually just moved it to exam 4.
Yes.
I can't really do that in this class because it's in the middle of an ID module. We're going to stare at ADHD and do a, central nervous system meningitis maybe. That would fit a little bit. No, we're not going to do that to you guys.
Okay, good.
So.
I have a question about, I think it was some of the articles that I saw for the bipolar articles more like a acute continuation and maintenance. But you didn't talk about continuation phase. Kind of. I don't know where that fits under.
So like maintenance phase, yeah.
Maintenance.
So like if you're looking at continuation of care, like that falls under your like you're looking more towards your maintenance therapy.
Okay.
Yeah.
So we're talking about different doses, I think, too, or similar doses.
Yeah, I'm not going to expect you guys to like go crazy with the dosing. I want you to know your plasma levels for your narrow therapeutic drugs. You need to know lamotrigine.
Yeah.
Or your lamotrigine. Just backwards and forwards, no lamotrigine. And that is specifically because of the SJS. If you remember how important it was for you to have to know the dosing, even if you forget the dosing, you'll remember why.
Yeah.
That's my rationale. I'm very happy that I have never had a student that has finished my class and is not known as soon as they hear lamotrigine, they're like, Stevens-Johnson syndrome.
Yeah.
Like, that's what I want you to do, okay? The rash side to that is so under-recognized. To put people at risk for that, it's just disgusting. And the first time you see a case involved, it's you'll never forget it. I had an 11-year-old girl that was one of my first psych consults when I started working as a specialist at the hospital. And they're like, you know, what do? We had to take her off Lamictal because it caused the Stevens-Johnson syndrome. Can we put her back on it? You out of your mind?
Yeah, no.
I'm not worried about her mental state right now.
Yeah.
How about we get it to where she might be able to see again, you know? But they're so uncomfortable with that drug that is like your area as the drug expert that you've got to be able to go to the physicians and like, no, don't do it, you know? Because especially more so, and we'll talk about this with the epilepsy side, your anti-epileptic drugs, especially with some of your neurologists, that they should be trained and they should know that there's a starter pack, but you would be amazed how many times they just prescribe the tablets and aren't using the starter packs.
Oh, we hardly ever had to order the starter packs in.
Well, there's been a huge education effort towards
Yeah.
that, but it still happens.
Yeah.
It definitely still happens.
Yeah.
And what the company has done to promote the drug to be used the right way and prevent you from having these issues in the Stevens-Johnson is they often just go in and they give the doctor's offices the starter packs for free.
That's brilliant.
Yeah.
Yeah.
So I know I worked at the Epilepsy Foundation. I used to go to a clinic for a couple months. I went every Wednesday, and we would open the door, and it was just Lamictal from like here to here. You know, it was just. And it made sense. Like, all of a sudden, it was like, oh, you know, topiramate is another one, the dosing. They call it Dopamax for a reason. But it's not, if you dose it at the normal levels, a lot of times you don't have to worry about that. Neurologists, when seizures happen, are so worried about getting you up to a therapeutic level that they ignore some of the side effects in between. And they're like, oh, the percentage of SJS isn't that big of a deal.
Matter.
And that gets missed. It still gets missed to this day.
Yeah.
And it's that one doctor that goes and does it, and you're going to have that patient in the ICU with that type of thing. It's just so. I've actually had I had a student that came up to me before the bipolar lecture one year. So I've been teaching this for like 8 years now. So it's indiscreet. It doesn't say whether it's UNE, PVA, NOVA, like, and literally walked up to me the day of the bipolar lecture that I was going to go through Lamictal. And she was like, I'm just wondering, like, I started on this Lamictal drug. Like, is this like a sign of it? I was like,
oh my God.
Don't take another dose and go see your doctor. We're going to talk about it today. See me after class.
Yeah.
And I got to the slide with the pictures, and there's nothing I could do at that point without short of. I was like, I said to her, I was like, don't be surprised in lecture. We'll talk after class.
Yeah.
And I look over, and it's just like the look on her face. I was
horrified.
Oh my God. It was the worst. It was just, But yeah, that stuff is, it's. You got to remember Lamictal, and you got to remember lithium with the renal, and I mean, there's certain stuff I definitely am not going to pull you guys into. Like, there's lithium pharmacokinetics and stuff like that we could spend a whole module just on like all the nuances of lithium. But you know, the stuff that I'm trying to have you guys hammering is the stuff clinically that you're going to have to know if you get asked a drug question on. Lithium is the one drug that doctors often don't have as much of a problem asking questions about, and they expect pharmacists to know because they know there's got to be a lot more taught in the curriculum on it. It just, It's So it's the one drug actually in terms of all the psych drugs that they, if you go to do vancomycin and aminoglycosides, and you guys learn about them in the hospitals, and the pharmacists actually go and do the folders on them for dosing, that lithium gets lumped into pharmacokinetic monitoring drugs. And most doctors don't even realize it.
Yeah.
If you're on the medical side, don't even realize it.
Yeah.
So, do you guys have anything from the narcolepsy or the OSA? Was pretty quick. I mean, don't take CNS depressants. Not everybody's fat, only 50%. And that's the huge misperception. I shouldn't say fat, obese, I'm sorry.
Yeah.
The narcolepsy is stimulants are recommended. Cataplexy, you're still looking at the sodium oxybate. Trying to think what else. Prozac and protriptyline for OSA. I forgot to mention that. For narcolepsy, it's really stimulants and modafinil.
Oh,
Yeah. I know. I gotcha. You're good.
Is Provision, is that like an abuse drug, say Adderall and all those other stimulants?
So back in 2007, the drug company actually tried to take that to market as Sparlon and make it like the next adult ADHD treatment drug. It is a stimulant. It does have stimulating properties, but it doesn't seem to be as easily abused. It does have, it is not a C2. It is a C3. I can't remember if it's a 3 or 4.
I think it's 4. Well, no, it might be 3.
I can't remember if it's a 3 or 4, but it is not a C2. It does have a little bit less abuse potential. And I think, as a whole, the drug has a little bit less abuse potential. But I don't think it's one of those drugs that, people are often thinking of, like your amphetamines or your Ritalins, as like the go-to abuse drugs. So the short answer to it is yes, it has abuse potential, but it's not as bad as your other stimulants. So, and I don't know if Dr. Teeter's going to go through that with ADHD, but I was actually looking forward to it. I was hoping it was going to get approved as an adult ADHD drug because it doesn't have as much of that negative connotation, and it's probably one of those areas that it gets underutilized is in adults, so it was specifically marketing it for that population. So, I think they didn't find that the benefit was more than other things on the market or something like that.
Yeah, I remember it was really hard to get approved. You had to show like sleep test. I remember it was prescribed to get it.
For part of the prior authorization?
Yeah, prior authorization.
Yeah. And I mean, I think it's good and bad to a certain extent that they're looking for sleep tests now, and they didn't used to do that as much. They would just slap you with a diagnosis, and might not always be right, and which often can cause things to get worse. But yeah, I mean, they were using it a lot more for other purposes besides narcolepsy because you could get around the C2 stimulant, prescription issues. So, but yeah, it does have from the studies that they were doing, it did show improvement in attention and focus. So, I don't know. It didn't get passed. But,
So, moving to schizophrenia, if you have a patient who has diabetes, high cholesterol, whatever, are you going to immediately think, well, let's go typical instead of atypical since they already are having some of these issues?
Your first line therapy, when we look at all your drugs, is still going to be your atypical class. I'm probably going to start out with something on the lower side of your metabolic profile, like aripiprazole is overall in your adult population pretty benign. all drugs in that class, including Abilify, have a higher chance to cause it in your ped population, which you still sometimes have to worry about diabetes with.
Right.
But if it is your general adult population, Abilify would probably be the first recommendation there because of the metabolic parameters.
So you'd still
Gedon-
try it, even though they might already have diabetes or whatever. You would still.
If it's the first time out, I mean, this is where like I want you guys to know. They all are kind of looked at as, you know, yes, it's a treatment option. Go ahead and use it as a first-line agent. Your doctors, if they have somebody who's got diabetes, are definitely not going to pick Zyprexa, probably not Clozaril. Risperdal is right underneath that. They might even go to that if they're looking at treating the fuller picture of the disorder.
Yeah.
But that also goes into more of your acute versus maintenance treatment. And we usually like to treat the same thing with acute that we will for maintenance.
Right.
Right? But there might be a time that I would have somebody coming in who's really psychotic, and I'm starting them on Abilify, and I'm not noticing enough of a response. And everything in the literature says monotherapy is not better, right? But I don't necessarily want to keep them on Haldol.
Right.
So clinically, you might end up putting them on Haldol and then trying to get them onto Abilify as an outpatient thing and switching over. You don't necessarily have to do them at both. Some might do it as like an acute thing, taper off. If you go by the guidelines and you go by what you really should be doing, yes, I would say you could go to Haldol.
Yeah.
You totally could go to Haldol. It's treating positive symptoms. Haldol is going to do the trick in most of your patients. You know, you don't always have a magic wand to say who it's not going to work in, but keeping in mind your typicals are all equal in efficacy. They're also equal to your atypicals for positive symptoms. And some would argue that maybe even like a Haldol in comparison to Abilify for positive symptoms, for an example. If you were to walk into a unit and say, this person is off the wall having hallucinations and delusions, a lot of your doctors aren't going to be thinking Abilify.
Right, you're going to go Haldol.
Yeah. It's at D2 blockade, done,
Yeah.
right? But if I'm thinking long-term management and I want somebody to be outpatient with that and not stop taking the drug because of EPS that are probably going to come up at some point, I'm leaning more towards Haldol. So, again, for the exam questions, I will be super specific.
Okay. All right.
I will be. But I have to get you guys thinking in that where you're going to take it when you go into practice mindset. And that's where it gets
gray
more fun.
areas.
Yeah. So I'm not trying to be vague. It's
No.
just,
I mean, there's a lot to this, and I tend to overthink things, and I read a case study, and I don't know.
Get passionate on your decision.
I do, a little bit.
Yeah.
Yeah. So.
Well, the whole idea is that you can make a recommendation. And one of the things that I always will do once I get, and there's going to be some different things that happen. We're actually, I don't know if you guys have heard, but we're blowing up the curriculum. We're completely redesigning it because it's a very old school model that Dr. Cormier that started at the college came and brought in. So we're doing an integrated model. And the first thing that I know the majority of us in therapeutics, I'm going to fight tooth and nail to make sure we have a lot more in is the case studies and actually having you guys make some of those clinical decisions, getting you thinking about it earlier as opposed to when you walk into APPEs and have to feel like you're really doing it for the first time. I can get you to think about that and do it in your groups, but until there's like some credit attachment to it with some sort of grade, it puts that at a higher level for students instantaneously.
Right.
So, yeah. But
I actually really like case studies. Like we did some in MedChem, we're doing them here.
Yeah.
Well,
that's what you guys are going to do when you graduate.
It makes you think. It really makes you think a lot of different aspects.
I don't care where you practice. It's really funny. I just had this conversation with my APPE students this morning. He was like, one of my, I'll pick on Jorge. He came in and he was talking. I was telling him, you're here for AmCare. You had Dr. McCall for your elective AmCare. Why was that an elective? And I'm your second AmCare. And he kind of went into why, because I was like, well, realistically, if you want to do more of the psych component, if you want to like, you know, dive into that more, since you've done some of your like hypertension, hyperlipidemia, diabetes stuff already, like we don't have to go over that all over the same thing again. Like let's do a little bit more, you know, on this side of things, and you know, you're still going to have those AmCare basics there. And he goes, you know, I don't want to like graduate and become a psych pharmacist. And I was like, I didn't think you did.
Yeah.
I really gear towards, I don't care where you practice.
You have to know all this stuff. It all comes into play.
I get furious. I did per diem community pharmacy throughout my residency and the 2 years I worked at the hospital. I loved it because like I did it as a student, and it still made me feel like I wasn't losing it, right? So I had a tech come up to me one day, and she goes, "Why do you talk to the patients so much?" I was like, huh? She's like, pharmacists that we normally have here, they don't talk to them as much as you. And it was funny because I had just counseled somebody on an SSRI, the guy that came in, brand new SSRI, and you know, she overheard me bring up the ED issues. Yep. Do you honestly think there is any man on the planet that is going to hear that a drug, or worse, they don't know, is going to cause erectile dysfunction? And it's going to, number one, either want to take that drug, or at least if you know about it and you know what to expect and how to handle it, like you have a good chance of, okay, this is a possibility. If it happens, I know exactly what to do. Right. You're okay with that when you walk out the door, compared to reading it and being like, what the hell? Or not knowing it and having it happen and being like, what the hell? And like you're ever going to go take that drug again. So, you know, something as simple as that, and like anxiety disorders and psych disorders, if there's like the littlest bit of imbalance there, the rest of everything else ends up going to hell. So the fact that something as simple as like an SSRI prescription going out, which is a huge number of drugs every single day, right? It just, I don't care where you practice. A lot of the older schools actually had psych as a required module, because otherwise you're not thinking about that side of it. You're just so like, you know, the guidelines, hypertension, it's easy. Okay, it's this, I do this. It's this, I do this. Lipid, okay, it's this, I do this. Like, you have to start getting out for a lot of your other disorders and like looking at the actual whole person. And you can't do that. You know, I had a doctor that said psychiatry is like an art. You know, it's all scientifically and evidence-based on how you're supposed to practice, but you have to actually understand a person before you can just throw a med at him. It's not like hypertension. So.
Is that like a unique thing about like psych pharmacy?
I would say there's a couple other areas. You know, like a lot of your straight-up medicine stuff, or like, you know, hepatitis and infectious disease and your medicines, you do have like a lot of those guidelines, but there are those areas like more of your neurological disorders. You get into a little bit more of those gray areas of really looking at like, for example, multiple sclerosis. When I take you guys through that next year, you know, there is your first line therapies that are like 2 different types of injectable therapies, and then you've got new oral meds that come out that some are more effective than others, but also carry more side effects. So like, you're still having to look at the patient and saying, what is the best choice for this patient? Like, there's always going to be like those drugs that are patient specific depending on what you do. So I would say more of your neurological side, you'll see some more of that too. And then I'm trying to think of, I've actually had that discussion. I'm trying to remember, we were thinking about that and doing like the compare and contrast, and where you kind of have to understand your patient a little bit more, like with the symptoms. And trying to think. HIV is more like you look at your resistance panel, your resistance profile. But it could be some of your infectious disease is a little bit similar, I would say, depending on what you're talking about, because you might have, for example, a urinary tract infection. This is an easy one to pick on. And so, you know, you look at the guidelines and you've got like macrobid, you've got Bactrim, you've got Cipro, you've got like different drug classes kind of, even when you're talking about some of those, and like, you know, whether Cipro or levofloxacin, and sometimes your resistance profiles kind of come in and help change what you would use, or patient's past history. So you definitely get some of that, but it's not as, you know, obviously behavioral symptoms are a little bit different than some of those others. So there is some of that same thinking in different areas. But yeah, it is a little bit more novel to psychiatry, I guess, more than any other specialty. So.
It's pretty exciting too. This is like thinking this way with it's like looking at several different things and picking one.
Yeah.
It's pretty cool that we develop that throughout the months, I guess.
Yeah, it's coming. It's all coming. It's funny, we do in Therapeutics 3, well, you'll have this in Therapeutics 2 as well, but so we give, every week your group has to meet and submit a group note, like every week on top of like coming in and doing your IRAT, TRAT exams, like, individual team, and then you come in and you discuss the SOAP that your group submitted that morning. It's always on, like, the focus of that week. But then we give master cases as well. So, like, for example, the master case I'm posting, we did with an Alzheimer's guy who's got urinary incontinence, and he's got elevated liver enzymes, and he's got osteoarthritis, and I'm forgetting something else we gave him. But that's like a typical elderly patient.
Yes, that's real life.
And so everybody always wants to be like, well, what do I do for this? But if you don't think about your whole patient, you're going to be like, what the heck? Like, I'm going on rotations, and I don't know what to do. So, yeah, it's like, if you've got an Alzheimer's guy, you guys will learn in Alzheimer's, like, there's 4 drugs for Alzheimer's, and then 3 primary ones that you kind of always start with. And if you take medications for urinary incontinence, they completely negate any benefit that your Alzheimer's meds have. You wouldn't believe. I almost hit one a week of somebody coming in who's on a urinary incontinence medication and an Alzheimer's medication. Nobody realizes that. It's like you're wasting their money on, giving them a med that is completely rendered effectiveless. No efficacy, I should say, not effective. No efficacy because it's negating it. And that is one of those that psychiatrists now know about from pharmacists maybe bringing it up. My psychiatrist, when I started there, didn't ever look at that. I had no idea. So something as simple as, like, your little old lady who comes in on Detrol, doesn't want to give up her Detrol, well, then don't bother giving her an Alzheimer's med. Yeah. Yeah, so. So anything else, if you guys want, just throw it out there for Friday then, and I can go over it, put it on the discussion board.
Will do.
Okay.
Thank you for doing this tonight.
Yeah, no problem.
It was awesome of you to do it.
What's that?
We all